for claims submission and reimbursement. And as we go along today, you'll see how accurate this statement is, particularly the fact that medical billing and coding is really somewhat of a translating process. So from the term medical billing and coding, we see that there's really two parts to this, and I would really like to break down the two parts and first talk about what is medical coding. So let me give a disclaimer first of all, I guess, to say I am not a coder, I am not a biller. I work with coders and billers almost every day. I was taught by very well qualified coders and billers as I got into this area 20 years ago. So I think I have a good working knowledge here, but I wouldn't want anyone to think that Mr. West is a coder or biller. I'm a healthcare attorney, and I work with those people all the time. So with that little disclaimer, let's talk about this whole issue of coding. And you know, medical coding is really a sub-industry in the healthcare world. It's become a major sector of the industry. There's national organizations, there are national certification bodies. This is a big business. And medical coding has a number of components, the first being diagnosis coding. And I could show you here a manual with the diagnosis codes. That manual is called the ICD-10 manual. It is maintained by the World Health Organization. This is a worldwide system of coding. Contains over 70,000 unique codes. And I remember the days when we were using the ICD-9, and that to me was quite complicated and had thousands and thousands of codes. And of course, ICD-10 upped the level of detail and complexity and codes are used when billing to tell the payer this is the diagnosis that describes the patient's condition. And there certainly may be more, and oftentimes there are more than one diagnosis code that is used in submitting a claim to a payer. After diagnosis coding, there is also yet another system and another manual of codes that are procedure codes, and these are in a manual called the CPT manual, the Current Procedural Terminology Manual. These procedure codes are mostly 5-digit numerical codes such as 99202 describing a new patient office visit. And these codes tell the payer what the healthcare provider did during a particular patient encounter. The CPT manual the rights to it are owned by the American Medical Association. It's maintained by them. It's updated annually, and like the ICD-10 manual, it contains tens of thousands of codes. So a little bit more about procedure coding. CPT codes are classified or divided into three categories. Category 1, which is really the one that we see most from day to day, are what are known as just the common procedure codes. They are mostly 5-digit numerical codes. Category 2 is a relatively recent phenomenon with what are called supplemental tracking codes, and these are 5-digit alphanumeric codes, and they are codes that help the government or other agencies track certain conditions such as diabetes or whatever, help them track those. And then category 3 are what are called temporary codes, and these are 5-digit alphanumeric codes, and those are often referred to as T codes, and these are codes that are assigned on a temporary basis while the coding committee at the AMA is making final decisions about a particular technology or product. So going to the Category 1 codes, which are really the ones used most often from day to day by healthcare providers, those fall into 6 categories, as you see on the screen there, for different areas of medicine. Okay, procedure coding actually, to make things more confusing, has 2 manuals. One is the CPT manual. The other is what we refer to as the HCPCS manual, which stands for Healthcare Common Procedure Coding System. This is sort of a supplement to the CPT manual and to the CPT codes. HCPCS codes are alphanumeric codes such as L1971, which would be a type of ankle foot orthosis, or L3000, which is an orthotic. And these codes typically are being used to describe durable medical equipment, prescription drugs, or other things. And these codes are describing things. They're describing items or products that are provided by the healthcare provider, as opposed to procedures or services that are being described by the CPT manual. The HCPCS manual is published and maintained by CMS as opposed to the AMA. So those are some basics, and then adding even more complexity, and if having to pick a diagnosis code and a procedure code were not hard enough, we then have another level here where modifiers are added to the CPT codes to provide additional information and specificity. These modifiers may be numbers, they may be alphabetic letters, and these modifiers are quite critical because they provide just a wealth of information, like the location of the service, for example. There are codes describing whether it's an office visit, a nursing home, a hospital, whatever. The modifiers can tell us the duration of the service, the number of units that were applied. They can help describe coverage issues, the logic and staging of a procedure. There's just a huge number of areas. They can tell us which finger or which toe on the foot is involved in the particular matter. So these modifiers are extremely important. Some common modifiers that I deal with are the 25 modifier, which tells the payer that on a single encounter there was a minor procedure performed, and that there is also an evaluation and management service being billed at the same time. And that modifier tells the payer that the evaluation was separate and significant in addition to the minor procedure that was being performed. Another modifier is the 5-9 modifier, which is used when multiple procedures are being performed, and it tells the payer, hey, these are distinct areas of the anatomy. So it's mainly to tell the payer that we are not trying to unbundle, but we are rather performing distinct services in distinct places on the anatomy. And then we have modifiers like GA modifier, which can alert the payer that the service may not be considered medically necessary, but it is being billed, sometimes just to obtain a denial. KX modifier telling the payer that the criteria for coverage have been met for a particular service. So these modifiers are really There's a large number of them, and they are very important in the coding and billing process. All right, we've talked about coding. Now we're going to talk about billing and what is, in fact, medical billing. And some experts divide medical billing functions into the front office or front end billing and back office or back end billing. The front end billing, as the name suggests, typically being done by people that the patient first encounters when they come into an office or clinic. And these functions are very important in getting the patient registered. We've all been through this process as we've gone to the doctor, getting our insurance card out and verifying coverage. And then in some situations, it's necessary for the front office people to be calling the payer, getting prior authorization, and verifying coverage for a particular service. And then also, typically the front office people are collecting copays at the time of the visit. So these are sort of the classic front office type billing functions. The back office billing functions, really the billing staff functions, have to do with filling out the CMS 1500 claim form, which I'll show you a picture of in a moment. This is the form which is used by Medicare and is kind of the industry standard for the submission of claims for reimbursement. I'll just throw up a picture of that right here. As you see, this form has many boxes. I don't know how many boxes, probably 30 to 40 different boxes that are filled out or populated. Today's world electronically, but in the older days, often manually. And this CMS 1500 form just contains a great wealth of information regarding a particular patient encounter. So where is that information gathered from? Well, a variety of places, from the patient's registration, documentation, and their demographics, to the super bill or encounter form that is filled out, sometimes information from the medical record or from the EHR software that is being filled out for a particular encounter. So the claim form, which is really, in my view, the central document for the entire billing process, is populated by information from these various places. And then once it is fully populated, that claim form is transmitted, again, typically electronically today, to the payer, usually through a clearinghouse. And that's an important entity involved in the process that's kind of back behind the scenes. So again, here is that claim form that is so important. Once a claim is submitted, the payer then must decide whether it is going to either pay the claim or deny the claim. And that process is referred to as adjudication. And the payer and the provider then initiate a series of documents. You know, there's a remittance that goes to the provider saying, yes, we're paying this claim and this is how much of it we're paying, and there's sometimes adjustments made for copays or deductibles. There's the long-standing EOB type document that is sent by either the payer or the provider to the patient, telling them what the payer has paid and what obligation, if any, that the patient may have. And then there's ultimately some reconciliation on the patient's ledger after the foregoing items are taken care of. So this is really obviously a very simplified version of the coding and billing process, but I think it's fundamental to understanding how the process works. All right, we're going to move from medical coding and billing now to a second fundamental issue, and that is, does the medical record support what was billed? And here I want to step aside a little bit from the slide and just point out a few things. So, much like filing of tax returns by taxpayers, the medical billing system is truly and somewhat shockingly to people based on an honor system. When a provider submits a claim for reimbursement, all the information that the payer has in order to adjudicate that claim is what is on that one-page form. The payer does not have the medical record in front of them. They have no knowledge of what actually happened in the patient encounter, short of what is on the claim form. And so therefore the payer is accepting at face value the representations on the claim form. Now, there's a lot of information on that claim form, and certainly the payer is not left without anything, but it's important to understand this honor system component here, that a payer is making a payment decision based on a one-page form. The reason I say this is I hear healthcare providers say all the time, Medicare paid the claim or the insurance company paid the claim, and so therefore we must have billed it right and everything must be fine. This is not true. Payment of a claim is not approval of a claim. It's simply payment of the claim. And it is really not until the payer obtains a medical record and reviews it can a definitive determination be made. And obviously, most of the time they are never getting the medical record, and so the honor system is what is prevailing. But on those occasions when the payer says, we'd like to take a deeper look at this, and they request the medical record and review it and compare what was billed on the claim form to what is in the medical record, and at that point, and only at that point, can they really make a definitive determination as to whether the medical record supports what was billed. The process of doing that is known as auditing, and we'll chat more about that in a moment. All right, so with that sort of aside, coming back to where we were on the issue of does the medical record support what was billed? I break this down into a who, what, where type thing. First of all, does the chart note or the progress note clearly describe what procedure or service or item was performed or provided? That's the first question. And that may sound simple, but I read medical records where I get to the end and I am not at all clear as to what was done. That is not uncommon. So it's fundamental to be clear in describing what was performed. Secondly, does the chart note describe why a procedure or service was performed or provided? And that why question is what is known as medical necessity. And that is an important term of art in determining whether a particular claim is payable or not. If it isn't, a service may be rendered, but if that service was not medically necessary, then it is not a properly payable service. And then finally, does the chart note clearly tell us who performed the service and what their credentials are? And that is also a critical component. So on the issue of medical necessity, that is traditionally established by the old SOAP note criteria of subjective, objective, assessment, and plan that most providers use in their medical records. And if the SOAP criteria is followed carefully and consistently, that is usually going to be very helpful and usually sufficient in establishing medical necessity. But unfortunately, all of those components don't often get there. I've heard some coders say that the key to medical necessity is a carefully phrased chief complaint, and then examination findings that bear out or explain or show, in fact, what the chief complaint is. And those are very, very critical components to establishing why you did this service, why it was necessary, and why it was reasonable under the circumstances. And medical necessity is a term that is carefully defined in the Medicare and Medicaid statutes. It's usually defined in all commercial insurance provider agreements and provider manuals. So very often the issue of coverage for a particular service is coming down to this question of, was the service necessary and was it really reasonable under the circumstances? On that issue, some documents are very, very critical. In the Medicare world that I work in almost every day, there are two types of documents that providers have to know about for purposes of their medical record documentation. And those are local coverage determinations, or LCDs. These used to be called they used to be called local medical review policies, or LMRPs, but about, I don't know, 10 to 15 years ago, the term was changed to LCD, and those are published by the Medicare contractors in the particular geographic area that they supervise, of which there are like 7 in the country. A newer document that is an adjunct to the LCD is what is called a local coverage article. And these are newer. These have really only been around, for the last few years in terms of common usage. And the Medicare system uses these documents to tell providers, here's what you have to document, here's what you have to show in terms of medical necessity in order for the Medicare or Medicaid programs, or basically the Medicare program, to cover something. When you get into commercial insurance like Blue Cross Blue Shield or Humana or whatever, you are looking at policies issued by a particular insurance carrier. Those are often spelled out in a provider manual document. And then when you get to Medicaid, the individual states often promulgate their own coverage policies, which must be consistent with national policy. So any provider who is working in these arenas, Medicare, Medicaid, or commercial insurance, if they are not familiar with these documents that apply to their specialty area, they are proceeding at great risk, because odds are they are not going to be satisfying the criteria. And most providers, it's good to know, are familiar with these documents, but I still go into offices frequently where I ask the doctor, are you familiar with your LCD for your particular jurisdiction? And when I get a blank look saying, or they ask me what's an LCD, I immediately am fearful that we are in a very difficult situation, and that the doctor, in fact, is billing in a way that his documentation is not going to support coverage. So I cannot emphasize too much how important these documents are on the screen are. Another point to make with doctors, especially I work with doctors all the time that are being audited, and the point I make to the doctors is, look, no one is accusing you of being a bad doctor. What they are accusing you of is not documenting your service appropriately. And there's a big difference between those two things. You may be the best heart surgeon or the best pulmonologist on earth, but if your medical record is not sufficient, you are not going to get paid, no matter how great the service was that you provided. So that's an important factor to recognize. So what are some of the top 10 documentation errors that we find? We could have a whole seminar about these, but just kind of giving you a feel for that. You know, failure to, after the doctor has typed in their electronic chart note, failure to just go back and read it and proofread it. And so often we see grammar, punctuation, words left out, errors made, just basically that could have been caught if someone had just reread their note. Failing to properly sign and date a chart note, and I mean not only manually but also electronically, this continues to be a problem, and we see it all the time. If the note is amended later, failing to do that properly, failing to include patient medications, both existing ones and new ones, failing to document the patient's response to treatment. If you're in a series of visits with a patient and you're treating them over a series of visits, it's critical to document how they are responding to treatment. One that I see all the time and that really seems to bother auditors is inconsistencies between the history, the exam, and the treatment. So the exam may say there's a problem on the right fifth toe, but the treatment is being provided to the right fourth toe. And the history may say the patient has pain in their right first toe. So we have these inconsistencies, and an auditor reads the note and is not able to give any credibility to what's going on because of those inconsistencies. Failing to properly document the chief complaint. Oftentimes I see notes that simply quote the patient. Patient says foot hurts. You know, that's entirely inadequate. You know, that, I mean, you can certainly say what the patient says, but you need to develop a more careful statement. You know, patient says, you know, the lateral side of the foot hurts in the mornings after activity. You know, it to be a more comprehensive statement of that history. So let's see, I left out a couple items. You know, from a risk management standpoint, failing to document non-compliance, failing to document no-shows, failing to document informed consent, failing to have an operative note for quote-unquote minor procedures can be a problem, and failing to have orders, particularly orders from a primary care doctor when those are needed and appropriate. All right, you know, a question that often comes up, and as I work with many healthcare providers, there is a dichotomy between those who bill with their own internal staff and those who use external or third-party billing services. And there is certainly pros and cons to the approach that is taken. Certainly when you're using your own internal staff, the advantages I see are your ability, the healthcare provider's ability to supervise, be closely connected, easier to communicate with someone down the hall as opposed to a third-party billing service in another state or even another country, which we're seeing often. So those are the pros I see. The cons of internal billing are often that the staff are not as qualified or experienced. There may be a lot of turnover, and so we're constantly training inexperienced people, and that is a very common problem. And so those are the cons of internal billing. As far as using a third-party billing service, again, you can often get the people with greater qualifications, maybe certified professional coders or others. You may be more efficient in generating revenue and collecting on revenue with them. But the downside with external billing is it's harder to supervise them. They're in a foreign offsite location frequently. And then the cost is often going to be higher with an outside billing service than with your internal staff. And I sometimes find a lack of accountability with these third-party billing services. They may be taking care of dozens or even hundreds of healthcare providers, and you may be simply one out of 100, and you may not be getting the attention or the service that you would expect. So those are some pros and cons on that particular issue. So I can't talk about coding and billing without going back, as I have in prior webinars in this series, and talking about the impact of electronic health records. And it would be wrong to sort of give an all or nothing impression that it's all good or all bad. Certainly there are many wonderful things about electronic health records in terms of the efficiency of collecting data, the ability to transmit that data across user platforms. And once you're within a particular health system, all your doctors and providers can see things. The ease of storage on a hard drive or the cloud, as opposed to filling your office with charts, and just having the ability to have templates that guide you through the documentation process. These are all great things about electronic health records, but there are clearly downsides, and those downsides are serious in terms of the generation of poor quality and really just junk records that are very verbose, that are repetitive, that are inconsistent, that are filled with irrelevant information, that carry forward information from prior visits that really doesn't apply to the current visit. We just see in today's world a lot of really bad medical records. Some softwares just don't fit well with certain specialties, and then the use of electronic health records, again, it's very time consuming and diverts attention from the patient onto the computer screen. And I've shown this little drawing before, but I like it so well. It's a little crayon drawing. I think it was drawn by a 10 or 11-year-old girl. She's the figure there in the center. She's sitting on an exam table in a doctor's office, and I guess to the right of her or on the right side of the screen are parents or nurses or whatever. But who do we see over there on the left side typing away on the computer? We see the doctor, who is not face-to-face with the patient, who's not paying attention to the patient, but is over there disconnected, typing away on the computer. Now, I know that's not a generalization that applies to every visit or to all doctors, but in this little girl's experience, that's what she saw going on, and that illustrates one of the downsides of electronic health records. Certainly in the subject of coding and billing, we have to be very conscious of fraud and abuse concerns. And the payers, Medicare, Medicaid, commercial insurance companies, they are constantly on the alert for things. They are data mining, they are reviewing data and statistics constantly in order to detect things. So the common things they're looking at are are upcoding, where a lower level code is what was actually done, but the provider uses a higher code, a higher paying code. Downcoding, again, the provider here is not gaining money on the system by downcoding to a lower paying level, but they're still coding and billing incorrectly. And providers do not get brownie points for doing this, surprisingly. They are simply viewed as incorrect coders by payers when they are consistently downcoding a service, even though it means less money is being paid to them. The problem of unbundling, which is where a provider, instead of billing a single code that represents a procedure, they sort of take that single code apart and they bill several services instead of a single service. And this goes back to an important document known as the National Correct Coding Initiative Manual, which is a guideline on bundling and unbundling. Providing services when there is not clear medical necessity is a fraud and abuse concern. Just failing to have a documentation of a service, which happens all the time, making improper coding choices or other problems, and then some other things, most payers do not cover services that are considered experimental and investigational. And with the speed of technology these days and the innovation in healthcare, many services are being billed that are not yet approved by the FDA or by the various payers and are still considered experimental and investigational. The practice of balance billing, where the patient is told, hey, don't worry about your copay or deductible, we'll just bill the insurance company and they'll take care of it, that's a problem. Of course, the area of Stark law with self-referrals, kickbacks, fee splitting, which is prohibited in Idaho among healthcare providers and others. And then something we see surprisingly often is billing of services by unlicensed or unqualified or uncredentialed personnel. And sometimes we see borrowing of billing numbers by one provider in an office from another who is not credentialed with a particular healthcare plan or may not have the credential or the licensure to perform a particular service. These can be serious problems that may be discovered in the course of an audit. So in a prior webinar, we spent time talking about coding and billing audits. We're not going to go into that in detail today, but providers need to recognize that there are many, many different entities out there. In the Medicare system alone, I can identify at least a half a dozen different contractors that do audits. And if you get notice from one of those contractors, it makes a huge difference which one it is and how they do the audit. With Medicaid, they are now very geared up with fraud and abuse units in most states, including in Idaho and Utah. The commercial insurance companies have also beefed up their auditing capability, and most of them have what are called special investigation units, or SIUs, that engage in very comprehensive auditing practices. So the payers out there, they are very much oriented towards preventing fraud and abuse in the system. We probably can't leave the topic of revenue and healthcare billing and coding without a brief mention on the subject of collections. Not a popular topic, obviously, but sometimes bills don't get paid, and this is most often a problem with the patient, not with the insurance company. And there are a number of things just to be concerned with here. I seen some practices that engage in absolutely no collection activity whatsoever, either internally or with a third-party service. And if a patient doesn't pay, they just drop it and go on their way. That's a very, in my opinion, poor business practice. But I see that quite often. In the Medicare system, there's a fraud and abuse component because Medicare and Medicaid expect the provider to take reasonable efforts to collect copays and deductibles. And what is reasonable really depends on what's commonly done in your community. But what I see most often is the practice of sending 3 donor letters to the patient asking them to bring their account current. And if those donor letters fail, then there is typically a referral to an outside collection agency. That final step is the one that is really of greatest concern because it's happened more than once that referring a patient to collection, especially a patient who is already very unhappy with their outcome, can prompt a lawsuit. So I would not ever say to doctors to automatically turn every non-paying patient over to collection. But certainly it is appropriate in many situations. And again, Medicare and Medicaid expect at least reasonable effort to be involved in collection action. Certainly, if a patient is indigent or unable to pay their bill for financial reasons, that certainly can and should be taken into account in this particular situation. We have a new scheme of laws enacted in Idaho with regard to medical collection. We have the new Federal Surprise Act that bears on this issue. All of those are sort of outside the scope of our presentation today, but they are certainly factors to be considered in this particular area. For just the last few minutes, we have the kind of a unique area that's come out in the last few years, which is the formation of boutique practices, so-called boutique or cash-only practices. And then we have another model known as direct primary care. So let's just make a few comments on those particular issues. So when a provider decides to transition from the traditional insurance or Medicare payer model to having a cash-only practice or a boutique practice, that's a major transition. It's really a night and day mode of practicing. If a practitioner is in the Medicare system, it is usually going to be required that they do what is called opting out. And opting out is a formal process where the provider sends a formal notice to Medicare that they are opting out, and then the provider has to give notice to patients they are no longer a provider and that the patient cannot submit claims on the side to Medicare. So this formal process has to usually be followed. And then of course there's just the question, if you don't have the solid insurance payers, are you going to be able to make it just depending on money coming out of the pocket of your patients? And certainly analysis has to be done. Some specialties lend itself to this, some clearly do not. But the biggest concern I've seen with providers is some try to have it both ways. They do a little insurance, but they do a little boutique practice, and that usually ends up being a hot mess because confusion results, and patients who the doctor thinks are paying cash or sending in claims on the side to the insurance company, and it just becomes really a nightmare. So I usually tell my clients, if they're thinking of this, you've got to either go one way or the other. You cannot play on both sides of the fence in terms of billing. There is also a new model that some folks have never heard of, and it really is an option for those who are in the general or family practice area, and it's known as direct primary care, DPC. And the way this works is that providers basically allow patients to subscribe or become members of the system, and these patients will typically pay, sometimes annually, more often monthly. They pay a subscription fee to be a member of the practice, and with that subscription, the patient is entitled to see the doctor for the services typically listed on a menu of sorts from the doctor's office. There may be 30 to 40 different things, like a well baby check, or whatever basic condition that people see doctors for all the time. So if it's on that menu, you're entitled to see the doctor free of charge if it falls under your monthly subscription. If it's not on the menu, you are either charged a specific amount for the service, or you are referred out to others. And so we see, we see this happening and becoming more frequent. I have some clients who are now going to this model, and it seems to be working for them. We've also seen that some employers are offering this as a fringe benefit to their employees, where they will pay their subscription fee to join up with one of these direct primary care practices, and they have this as a benefit in addition to their health benefit plan with the particular company. So this area, again, that we've been talking about, the area of coding, billing, revenue generation, is an evolving area. I expect to see lots of things change in the coming years. So that really concludes my presentation. I'm going to ask Angie if there have been any questions collected, or if anyone has any questions at the present time. So Angie, do we have any that you become aware of in the chat room?
No, we do not have any questions coming in through the chat at this time.
Okay. If anyone has any questions, if they want to type in quickly, I'll pause for just a moment. While we're waiting, I really do want to make a pitch for our last two webinars in this 12-month series. In July, a discussion of physicians and physician practices, or any type of healthcare provider practice. That topic is going to cover items such as different business entities that a provider can form. It will talk about employment law questions for practices, and buying and selling practice, so transactional issues will be covered. And then in August, the final session will be on the subject of post-acute healthcare. So those are coming up. I hope those of you who have been attending all along can finish out the series, and we appreciate your participation.
Okay, I do not, oh, here we've got a question from Dan. Is billing done by a large healthcare system employee and the doc doesn't have easy or quick access to the final billing decisions? How responsible is the doctor for the billing?
That's a great question, actually, and I deal with that question frequently. And ultimately, the healthcare provider who bills for a service under his or her billing number is going to have ultimate responsibility, but there may be an adjustment of that responsibility in certain circumstances. If the services are being billed under a group number, which is probably the case based on this question of a large organization, the audit is going to be directed towards the group and the entity. So the auditors follow the money, and the money is going to the group entity. And so that is who they are going to chase. They are going to chase the group for the money, not the individual provider. So that is some relief or comfort to the individual provider, is that they are not individually going to be audited or asked to give the money back. Now their group may look at them and say, hey, your services weren't paid. We need to adjust your production based on that. The other thing is, if it ever got to a fraud level, it has happened more than once where the group's billing staff are upcoding or billing improperly without the knowledge of the individual healthcare provider within the group. And certainly in that situation, the provider will have a defense to any allegation of fraud and abuse against him or her. And I have defended more than one provider who was in that exact situation, and we were able to get them exonerated by the fact that they did not have visibility to the final billing claims that were being sent out in their large groups. So that is a great question, and that scenario does happen.
Great. I don't see any other questions at this time. Oh, and Dan says, thank you, Kevin.
Okay.
And I just want to thank everyone for joining us this morning. And thank you, Kevin, for some great content here. You will receive an email with the PowerPoint and recording of this webinar. And also one last pitch for next Wednesday, July 20th. It'll be our second to last presentation, and it'll focus on physicians and practices. You should get an invitation to that in the coming days. Anything else, Kevin?
No, thanks everyone, and good to see you all.
Great, thank you.